We're here to talk today at this panel about population health, which is a descriptive phrase that the profession and others use to talk about how we've been trying to grapple with and adjust to changes in healthcare delivery, healthcare payments, and the demand on healthcare as a result of changes in the country and changes in our community. And I'd like to start there. So let me throw out the starting point. One of the major changes that has driven this interest in population health is the shift from wanting to recognize or pay for services versus wanting to pay for outcomes. And all part of this is the whole concept of quality in health care and so on and so forth. But I wonder if you could help our audience understand what that shift has done and what it means in terms of communities. Yep.
Jim, I would take it one step further in saying I think the message we're getting in the healthcare sector is people want to pay for health. And I always think of it in terms of metaphor of a river or a stream, and we've traditionally been downstream, just taking care of people as they come at us. And it's kind of obvious we have to go upstream now and make sure fewer people are thrown into the river. And that's what population health, both within the clinic and in the community, is all about.
And I think that I would like to say that, as Tim has pointed out, is that we got to work more upstream. And so when we think about population health, especially from a preventive perspective, we're talking about things that traditionally hasn't been as identified so much in a clinical setting. And that, from a public health and a population health perspective, addresses creating a culture of health. And that has to do with looking at what is the nutrition, what is the access, what is the availability for somebody to be able to have housing. What about their economic well-being? All of those things really play into addressing a population of health, and so that we have a continuum of well-being, and how do we get each person to their optimal level of health, whatever that may be.
And so one of the reasons, picking up on Pam's point, one of the reasons that the reimbursement system matters so much to this conversation is, as you just heard, there are many, many drivers of good health that are not within the direct purview of the healthcare delivery system, and I don't think any of us at this table would suggest that it's the responsibility of the healthcare delivery system entirely to take care of all those needs. And yet, if we acknowledge, as I think we do, that health really is that complete state of mental, physical, and emotional well-being, then we don't want to miss any opportunity that we have to make those improvements in people's underlying health and well-being. So that means that by shifting, in this case, healthcare reimbursement more in the direction of outcomes and value, we can, in theory, free up some resources, provide some more flexible resources inside of clinical care to allow for referrals to community services or allow for assessment of the kinds of needs that both Pam and Tim were talking about. That's why the shifting payment system matters so much to this conversation.
I would agree. I think that one of our biggest opportunities is to step up as a country and actually compare ourselves to the Europeans. We spend half as much in social services. And if we can attack this in two ways. The health systems and physicians and nurses and advanced practitioners can work on the high-end costs and reducing that and having good outcomes. But we need to invest on the other end to prevent. Businesses run best by not having emergencies. They run best by preventing emergencies. We have always been the emergencies.
You know, I think that the change is a positive one. We're in an evolution, but we're trying to undo decades of the more we do, the more we make as an industry. But I think we're moving from react and respond to predict and prevent. And we're using big data, medical information systems to, we know precisely what we ought to be doing. 70% of what we're treating in the healthcare delivery system is lifestyle-driven illness. And we know it's treatable, manageable, and curable. So if we can get upstream, to Tim's earlier point, we can predict and prevent some of these diseases and downstream illnesses. We can get a better outcome and spend less money. But it takes an engaged patient, consumer, in being involved with their care. And I think we're spending money today trying to keep people out of the hospital, which is unlike what we grew up in the industry trying to do. The more we do, the more we make. I'm now, as a provider, trying to be in the, today I'm in the healthcare business, tomorrow I want to be in the business of health. And I think that's going to take an awful lot of upstream public health collaboration with partners in the community, and most of all, an engaged patient.